I'm sorry I didn't capture all that poetry that you just said. Ashutosh.
Welcome back, clinical problem solvers.
Woo!
Woo!
I forgot to hit record, but this is why you have to come and join live because you miss out on all the wonderful things that happen because I forget to hit record. Thank you for that incredible introduction. I'm so glad that Austin helped you. Did you guys actually meet in person or were you communicating electronically?
No, we were just chatting on WhatsApp. We
Okay.
didn't get the chance to meet each other, but it was so much fun.
That's incredible. Well, thank
Ashutosh, after today's presentation, give Robbie's WhatsApp number to the patient in case they have any further questions.
All right, Ashutosh, we're ready whenever you are.
Okay, so we're starting the case. We have a 30-year-old female presenting with chest pain. So that's the chief complaint.
I know I'm supposed to kick it off, but it doesn't feel right when I have an extraordinary ED physician who sees this on a regular basis. Robbie, mic to you, my friend.
Oh, you got it, Prof. Rez. I just want to check in briefly with Elena. Are you having any issues sharing the screen, Elena?
For some reason, it doesn't seem to work. I don't know if someone else
Oh,
can share the screen and I'll
no
just
problem. There's
do
no
the
problem.
scribing. Great.
Another reason why you all should join live. Yet another. We're just going to build them up today. But Elena, don't worry about it at all. Since there's only 2 words of information so far, you can take your time. And I think that when we hear the words chest pain, our reflex immediately jumps to the sinister causes. And I think if you've been part of this community for a while, that reflex is honed. And the practice in this case is to reflect on what happens differently when a patient is young. And at the end of the day, it's a complex mathematical analysis, what happens when the patient is young. Because if we take a simple math equation of the numerator being all the scary things and the denominator being all the not scary things, if you just visualize that, like scary causes of chest pain over not scary causes of chest pain, what happens to a younger patient with that calculus? Well, I think intuitively you might reflect on the fact that younger people have many more frequently benign diagnoses like costochondritis and GERD and all sorts of things. And so the denominator of benign things is much, much, much bigger. And vast majority of patients who are young with chest pain do just fine. The question is, what happens to the numerator? What happens to the list of sinister diagnoses? And at first glance, you might immediately say, well, the patient who is younger is much lower risk of acute coronary syndrome. And that's 100% true. The rate of CAD is much lower in patients who are younger. But is CAD, coronary artery disease, the only mechanism to get acute coronary syndrome? And the answer is no. There are many other ways you can have an acute coronary syndrome apart from plaque rupture. You can have a dissection, an embolism, a vasospasm, and all those things are much more common in younger people. You can also have completely unique things to the younger population, including congenital heart diseases, anomalous coronary arteries, so on and so forth. So when you do this calculus, you ultimately realize that both the numerator and the denominator increase, that both the rate of benign conditions are higher, and also the rate of possible serious conditions is higher too. Both are higher. But there are 2 up arrows for the denominator, and there's 1 up arrow for the numerator, resulting in this net analysis for 100 patients of many more benign diagnoses in younger patients, but the numerator is still higher. And when you first meet the patient, nobody cares about the denominator. No one who's meeting a patient with 34 with chest pain ever thinks about the benign diagnoses until you've ruled them out. So if you're thinking about this simply as a math problem, you're like the numerator is higher and the denominator is higher, but the denominator is much, much, much higher. But in the moment, nobody cares about the denominator. It's all about the numerator. So right now, in this moment, what's happening in my brain, I'm more worried than I would be in a 64-year-old person right now. The probability of me being more worried at the end of this experience is much lower. But at the beginning, I can't miss coronary dissection. I can't miss a pneumothorax. I can't miss congenital heart disease. I can't miss a marfanoid aortic dissection. I can't miss those things. I don't worry about those things in older people. I worry about them in this person. So that's the calculus in younger people. Initially, the range of possibilities is wider. At the end of the journey, most of the time you can breathe a sigh of relief, but you still have to sweat it out. All right, Ashutosh, tell us more, please. I think you're muted unless my ears aren't working anymore. Oh yeah, you're muted. You're muted. You're okay. It's okay. Another reason to come live, y'all. We're just building it all up.
Sorry about that. So amazing discussion. I'll move towards the HPI. So the chest pain began 4 days prior with no clear trigger. It was left-sided and it was like on and off, lasting for 5 to 10 minutes at a time. It was associated with shortness of breath, but no radiation. It was not positional, and there was no clear exacerbation with exertion. No palpitations as well. And during this time, when she was developing the chest pain, like over the course of 4 days before coming to the ED, she also developed facial swelling. Initially, it was noticed on the right upper lip, which was more swollen compared to the left side. Since it progressed to involve her cheeks and eye on the right side, and gradually she felt like the left side has also been swollen. So it started from the right side and it progressed towards the left side. No new soaps, detergents, or beauty products, medication, or any other trigger were identified. There was no stridor, no throat tightness, no trouble swallowing, no abdominal pain or diarrhea. Review of system was otherwise negative, like including recent infections, constitutional symptoms, and rashes. So that's all what I have for this aliquot for HPI. Should I stop, or do you want me to go ahead with the past medical history?
I think we should hear some Prof. Rez magic now. There's a lot of interesting stuff. What are you thinking, Prof. Rez?
I love it. Yes. Ashutosh, you're creating a very interesting case, my friend. We miss you from the Rupus times. I think this is what I would honestly do if I were seeing this patient in the emergency department. I would quickly ask to look at a prior photo. This is, of course, after I've ruled out any signs of upper airway obstruction. This could include stridor. This could include drooling. This could include hoarseness of the voice. So priority number one, there's no upper airway obstruction where I need to get ENT to come down and scope and secure the airway. Then we know that's not the case here based on what Ashutosh told us. So then I go to priority number two. I need to look at the prior picture. The prior picture will allow me to assess the facial swelling with accuracy. It's almost like, when you have a patient who's anemic or has an elevated creatinine, what do? We look at the prior value. This is the same concept. We look at the prior picture. Facial swelling is fascinating because we all have an approach to swelling in general, where we start with the heart, liver, kidney, maybe some demostasis, maybe some medication. But something unique about facial swelling is that it's non-gravity dependent. So that same schemata does not apply to facial swelling. When you have facial swelling, there's two primary considerations. So like a tier-based approach to facial swelling. One is, are we dealing with angioedema? Angioedema. And angioedema can involve the mucosa, it can involve the face. And that's literally when you have the endothelial cells become leaky, so fluid extravasates out, so you get swelling. The second thing is SVC syndrome. Here, the unilaterally or symmetric nature of it can help you make progress. Like if you just had unilateral swelling, it could still be consistent with angioedema, but then you might even consider allergic etiology. So I have chest pain and we have facial swelling. It's hard not to consider SVC syndrome in this context. So I think angioedema, SVC syndrome, and then something else that causes facial swelling more than swelling else than other causes of diffuse swelling is nephrotic syndrome. But that is not going to be my lead hypothesis here. And what I would do next, in addition to, flush out the past medical, et cetera, when I get to the physical exam, I'm actually going to have the patient do this. This is known as Pemberton sign to see if this swelling worsens. And I'm going to ask them one more question. Is the swelling worse when you wake up in the morning? This is a very important question. Why? Because if we're saying that this is SVC syndrome, when they stand up and they go about their day, the facial swelling actually improves because you have gravity coming into effect. So Ashutosh, I look forward to the next sequence of data, but I'm most concerned for SVC syndrome because of the chest pain. Angioedema is fair play, and then nephrotic syndrome is something I put on the back burner based on what you have mentioned.
Professor, can I just say one quick thing? I can't believe, Elena, you've bounced from like being nervous that you're doing your first scribing to not being able to share the screen to like having your HPI so clearly organized and the italic. I love the like negative italics. It's really, really helpful. So awesome job with the scribing.
Okay. So moving on to the past medical history, we have the patient has generalized anxiety disorder, irritable bowel syndrome. The chest pain was new, but she had previously had the episodes of facial swelling requiring ER evaluation. The diagnosis was not very certain when we saw the patient, like what was she diagnosed with at that point of time. But she did mention that she did not require intubation, but had a little bit of trouble breathing. So the patient at that point of time was discharged with EpiPen. There is no significant past surgical history. Her mother had similar episodes of facial swelling and shortness of breath without a clear trigger. For social history, she lives alone. She works as a hairstylist. She sometimes uses alcohol socially. There is no tobacco or substance use. And she's on buspirone for generalized anxiety disorder. She has previously seen immunologist, and she has like many known allergies, including peanuts, penicillin, latex, and pollen.
Oh, Professor, I think this is a very intriguing history because not only do you get two dimensions are clarified for you about this case. The first is that the history predates the patient's existence, and that the history of this disease is quite possibly linked back to her mother. And the initial instinct is to always, whenever multiple family members are affected by a same issue, is to immediately think, is this genetic? And that's my reflex too in most cases, but let's remember that other things were also communicated amongst household participants, including infections and allergens. So just because family members share the same thing does not mean those things transmit through genes. They could transmit through infections and transmit through allergens. And here, an allergic phenotype may be combined with allergen exposure. So I just immediately tempered my enthusiasm to think this is a genetic disease, which I'm starting to worry about it by the realistic consideration that there's a vulnerability genetically and the real issue is allergen exposure. And that issue is augmented by the patient having so many allergies. But I think the most intriguing history is the fact that this issue seems to be episodic. And now, unfortunately for the patient, but fortunately for diagnosis, it seems to be episodic and progressive, meaning that it's understandable how episodes of facial swelling can evade diagnosis, and sometimes you just have to wait for the disorder to evolve. And if the chest pain is linked to the underlying disorder, it may serve as the key clue to allow us to make progress on what's going on. But I think it's fair to say that episodes of facial swelling lie on the spectrum of angioedema and urticaria. I'm trying to think, is there any other consideration that causes bouts of facial swelling? And I can imagine some things that can do it with a lot of stretching and having to really twist illness scripts. So operationally, I think I would just call this recurrent episodes of angioedema. And I think the question fundamentally, whenever you're dealing with angioedema, is you're trying to figure out the mechanism. Is it histaminergic angioedema, or is it bradykinin-mediated angioedema at first glance? And in general, histaminergic angioedema tends to be very dramatic, and it's dramatic in two ways. It tends to be very abrupt in onset, and it tends to be extensive, meaning the patient has angioedema and urticaria. In stark contrast, bradykinin tends to be kind of zen and chill. It isn't so dramatic in its onset. It's kind of just slowly, as kind of what we heard about this patient's HPI. She had 3 days of facial swelling, started on the lips and started to get bigger. And it tends to be more chill in that it doesn't cause urticaria. So at first glance, I think this patient is having what seems to be bradykinin-mediated angioedema. And the family history is evocative of the possibility that she might have a heritable form of bradykinin-mediated angioedema. That enthusiasm is a little bit tempered by her allergies, but that's the kind of working hypothesis that my mind is starting to grapple with. I'm going to hold off on reflecting on the different types of heritable forms of angioedema, but I will tell you, it's fresh in my mind because of an RLR CP Solvers case that Prof. Rez presented to me. And I actually put together a teaching video on this exact same topic literally less than a week ago. But I think it's too soon to deploy that now. And I'd love to pass the mic to Prof. Rez to see what he made of this data. And also, Prof. Rez, I'm curious, I haven't thought about it yet, and I will after I pass the mic to you, about how we might start to link this with chest pain. Anyway, what are you thinking, Prof. Rez?
I think, something that we've emphasized over the last several weeks is how important it is to identify the problem. And the frame of episodic, non-dependent edema prioritizes angioedema. And by the way, angioedema more often is unilateral than bilateral. So Rabih, I am right there with you. And one way to remember that bradykinin is just the more zen and chill one is with the word Brady. Brady is slow. Bradykinin, slower in tempo. But I think we get more information, and already my mind is primed for like what kind of labs and stuff will be fruitful. But I'm going to let Ashutosh guide us so we don't drop the anchor too quickly and completely fail where we would be premature closure. But if we get it right, then we're recognized as geniuses. But we'll temper our enthusiasm.
Love to discuss that. And the chat is on fire as well. I read a few comments, and all of the thoughts are really amazing. And moving on to the physical exam and the vital sections, she was afebrile. Her blood pressure was 130/70, heart rate 110, respiratory rate was 24, SpO2 was 96% on room air. General exam, she was mildly anxious appearing and tachypnic, but there was no evidence of use of accessory muscles. And for cardiovascular exam, the rhythm was regular, a little bit tachycardic, no murmur, rubs or gallops, and no any added sounds. JVP was normal as well. Chest wall was non-tender to palpation. And lungs was clear with no evidence of stridor. On the skin exam, like puffiness was noted on both right and left cheek, jaws, and eyes. There was no tongue swelling, no rashes, no urticaria, and no edema was noted elsewhere. And the Pumbert sign was negative as well. So just to add on to here, that's all for the examination sections. Should I move on to labs, or shall we stop for here?
Maybe you can give us prelim labs, Ashutosh.
Okay. So our WBC was 9,000 with with mildly elevated absolute eosinophil counts. Hemoglobin was 12.3. Platelets was 160,000. Sodium was 134. Potassium was 3.4. Chloride was 100. BUN was 15, and creatinine was 1.1. Glucose was 108. Calcium was 8.6. Phosphorus 3.5. Magnesium 1.6. AST was 36, normal. ALT was also normal, 42, just a little bit above. Alkaline phosphatase was 55. Total bilirubin was 1.1. Albumin was 4, and CRP was 20.
And Ashutosh, the normal CRP range in your lab?
It was less than 10.
Less than 10 is normal.
Okay. So CRP was elevated.
Got it. Can I ask for one more data point if possible? Because I think it'll allow us to make a lot of progress. Do you have complement levels, C3 and C4?
Yeah, I was saving that for the later part, but just because
okay, save it for later. No, save it for later. Sorry, Ashutosh, I'm a little too excited. You gotta calm me. You gotta temper me. You gotta make me zen. Maybe I just honestly, I'm gonna leave the lab to Rob, because Robbie, the more and more this case is unfolding, the more and more it's sounding like the teaching video you made last week. I'm actually going to leave the lab for Robbie, but I just want to make a comment on angioedema because it's a really confusing topic. So I'm going to reiterate much of what Robbie had said, but it's really important. You see, with angioedema, when you're dealing with it, at time point 0, airway. That's the most important thing. And very low threshold to give IM epinephrine, antihistamine, and steroids. But the IM epinephrine is so important, especially in the first time presentation of angioedema. Robbie told you, and it's really, why is angioedema so tough? It's because of when you think of mechanism for diseases as your framework, it's very difficult. Like think about when we talk about hypoxemia and we're like, is there a shunt? Is there an aid? Is there this, that? Who knows? It's very tough to learn medicine based on mechanism. But with angioedema, it's actually not just two mechanisms. There's a third mechanism. There's histamine, there's beta-kinin, and there's leukotriene. You see, the histamine is released from mast cells, and histamine can cause a rash. So a rash and anaphylaxis is pretty much diagnostic of a histaminergic process. But this is where you got to be careful. The lack of rash does not exclude a histaminergic process. Its presence just further strengthens the hypothesis of a histaminergic process. And why is it crucial to try to put it in one of these three buckets? But even before we do one of these three buckets, let me teach you something much more practical. When you have angioedema, you know the airway is secured. Just look at the medication list for God's sake. Look at the medication list. Are they on an ACE inhibitor, NSAIDs? Are they on OCP? So she's 34. Look at the med list. These are causes of angioedema. NSAIDs is through leukotriene that can lead to angioedema. ACE inhibitors is through bradykinin, can lead to angioedema. And I believe OCPs can do it too. So it's really important to scan that medication list. But when we get back to the histaminergic cause, the question is what causes mast cells to degranulate and release histamine that leads to leaky vessels that potentially leads to urticaria? It can happen through multiple mechanisms. Like if I have an exposure to an allergen like a peanut, my immune system will synthesize and release IgE. I won't have an allergic reaction right there and then, or an exposure to an antibiotic. I now have IgE. This IgE touches the mast cells, and the mast cells are locked and loaded. So the next time my body sees that peanut, it sees that antibiotic, the antigen from the offending agent binds to the mast cell, and it's explosive. And that's why histaminergic is explosive, mast cell degranulation. But there's another mechanism. When we give patients contrast, when they get opiates, why do they get itchy? You can get direct mast cell degranulation without IgE. And the epinephrine is really for the anaphylaxis component of this. The antihistamine and the steroid is more the itch that's associated with histamines. So if it was rapid onset, if it involved a rash, if there was an exposure, a bee sting, a peanut, an antibiotic, boy, you're making a strong case for mast cell degranulation. But here, what we have is episode, no rash, and a Zen process. So everything is screaming bradykinin mediated. So I just want to talk a little bit about bradykinin mediated. And when you're dealing with bradykinin mediated, there's really two possibilities. But first, understand, why does bradykinin lead to angioedema? Bradykinin, just like histamines, leads to leaky vessel. Why do ACE inhibitors are more likely to cause cough and angioedema rather than angiotensin receptor blockers? Is because you impact the ability to degrade bradykinin. You get in a hyperbradykinic state. So that is an acquired cause of bradykinin. Then there's a hereditary form of it. And this is where it can get really confusing, and this is where complements are most useful. You see, the complement cascade is a complement to the immune system. It complements the immune system, both innate and adaptive. It's that sort of in-between zone. And you get complement consumption when you either activate the immune system because you have an immune-mediated process like lupus, or an infection that revs up the immune system because you want to complement the immune system. It's involved in tagging bacteria and phagocytosis and all of that. But that's not the only circumstance that you get complement activation. The complement activation can happen independent of immune system stimulation. And that's really what we're trying to explore here. And that reason is because you have an inhibitor of an inhibitor. So typically when you have complement activation, you have a C1 esterase, an enzyme that breaks down complement, reduces its level. But when you have an inhibitor of inhibitor, so a C1 esterase inhibitor of the C1 esterase, all of a sudden you have difficulty controlling the complement cascade. So in this form of C1 esterase inhibitor, it's basically the complement system gone wild, and this leads to alterations in complement level. The C4 is much more helpful here because the complement cascade has a classic pathway, an alternate pathway, and another pathway. But when you have the alternate pathway activated, you get, I think, primary consumption of one of those complements. But I think C4 is a sensitive one. So that should be your screening test. And then you would send C3 and C4, and then you can actually measure C1 inhibitor function and level. But let me give the mic to Rabih. Rabih, please reiterate some of the important stuff I just talked about, and then incorporate that CBC, baby, and tell us where you are.
I would completely decline your request because there's no way that I can reiterate with such clarity and such precision. In fact, I was thinking of poor Mario this whole time, who last minute jumped in to do teaching points and had no idea that this would be up his sleeve. So Mario, thank you so much for helping out. And you should blame Ashutosh for the incredibly complicated case and Reza for his brilliant teaching as to the amount of work that you're having to do. And I love that. I have nothing to add. It was just so crystal clear and so easy to follow. It was as zen as bradykinin itself. And the problem I'm having, Prof. Rez, quite frankly, is what do I do with the eosinophils? Because if you're trying to be authentic about the exercise between histamine and bradykinin, there's a much more robust association with eosinophils and histamine rather than eosinophils and bradykinin. So you just heard the overwhelming evidence for bradykinin that Prof. Rez said. So the question is, what do the eosinophils do? Do they completely sway you back all the way to histamine? Or do you start to say, well, wait, are there any bradykinin-mediated diseases that are associated with eosinophilia? And the answer is yes, there are. They happen to be exceptionally rare and not worth thinking about, but I want you to know they exist. And I'll leave it at that. I don't think they're likely enough to be invoked in this case, but I just want to put a note and a flag in that eosinophils are elevated. If you're making a table, like Prof. Rez just said, the eosinophils go more histamine than they do bradykinin, but there are bradykinin associated conditions that can cause elevated eosinophil count. The other dimension that we'll have to analyze is, are we calling this an inflammatory allergic disease because of the elevation of the CRP? And I think that also is something that hangs in the balance because the CRP elevation isn't dramatic, it's there. So I'm right there with you, Prof. Rez. I think the labs cause a little bit more trouble than they are helpful. And the trouble they cause is the eosinophilia elevated enough that we should move towards histamine, or do we stay locked in bradykinin? And is the CRP elevated enough that we call this inflammatory, or is it pure noise? And I think that none of these things are dramatic enough that they move the needle higher than your compelling argument for a bradykinin-mediated process. But they do, I think, make us wonder, what tricks does Ashutosh have up his sleeve? All right, Mike, to you, my friend.
And also wonderful thoughts in the chats. So I'll give us a little bit of more labs and imaging now. We did a chest X-ray, which was normal. Our troponin, high sensitivity troponin, was in the range of 300, the normal being less than 15. ECG showed ST segment elevation in lead 2, 3, and AVF. And I don't have the ECG image right now, but I do have a representative image if that is necessary. But it's almost like lead clear ST elevation in lead 2, 3, and AVF. So as we were also talking about C3 and C4, both C3 and C4 were normal. C1 inhibitor activity was normal, and yeah, I think I'll give you a little bit of more data here. Before I end up with my last aliquot, so the cath lab showed non-obstructive coronary artery disease, and echocardiogram was pretty much normal, all normal, left ventricle, right ventricle function, no wall motion abnormality, normal right ventricular pressure as well. And in cardiac MRI, there was like no evidence of myocarditis or pericarditis. So yeah, that's about the imaging, and then the ECG, and then C3 and C4 as well as C1 inhibitor activity was normal. Do you want me to stop here, or there's one? There's
yes, please. It's so intriguing. One, I think that Ashutosh, you're presenting this case flawlessly. I think you're really allowing us to, whenever your discussants don't have a good handle of what the problem is, that is so reflective of real life. And I think it's always been, is this histamine, bradykinin, or as Prof. Rez corrected me, I already forgotten about leukotriene, and I appreciate him reminding me. And I think now the needle has swung significantly towards histamine. And I think the reason for that is, despite the atypical presentation, the cardiopulmonary consequences are very much histaminergic. And I'll just try to make an argument as to why that's the case. And it really has to begin with analyzing what our differential diagnosis for ST elevation is. And anytime you hear ST elevation, you should immediately tell yourself, why isn't this an acute coronary syndrome? And here, your immediate reason to pause might be that this patient is young and doesn't have any atherosclerotic risk factors. And so let me think of what else causes ST elevations. And there are 3 other immediately actionable hypotheses. The first is a pulmonary embolism. The second is Takotsubo. And the third is myopericarditis. And so let's go through the data that helps us analyze those things. A TTE without Takatsubos is virtually eliminates that possibility. And an MRI without myocarditis or pericarditis virtually eliminates that possibility. So we're left with saying, could this be a PE? And the answer is no, in large part because when a patient has a troponin from PE from right heart strain, they're much sicker and might have much more hemodynamic compromise. So we're left with saying, wait, is this ACS with a normal cath? Can you have ACS with a normal cath? And the answer is absolutely yes. And it goes back to the numerator that we talked about. We talked about how you can have acute coronary syndrome without plaque rupture. And what is the most common reason you can have cath negative ACS? Vasospasm. What molecules can mediate vasospasm? Drugs like cocaine, medications like ergotamine medications, and histamine. So I'm starting to worry that this patient has histaminergic disease, and the EOs and the cardiac hypotheses support that notion. In fact, the Prof. Rez has also presented a case of histamine-mediated consequences to me on rlrcpsolvers.com. That was a sneak plug, by the way. I'm making it explicit. Yes, rlrcpsolvers.com. You should totally check it out. Anyway, that entity is called Kounis syndrome, Kounis, and it describes the consequences of histamine on the heart, and it happens in two ways. First, coronary vasospasm, and the second is Takatsubos. Both can happen. And the combination of both vasospasm and Takatsubos can happen in a small subset of patients, and that syndrome is called ATAK, attack syndrome. I'll spare you the abbreviation because I forgot it. And so I'm really worried that this patient has histaminergic disease based on the cardiac consequences. But I'm really curious how you're analyzing this data, Prof. Rez, and what you think might be what you're thinking about the underlying issue here.
I am thinking exactly what you are thinking. That was so eloquently laid out in that we know we don't have acute thrombosis. Sometimes dissection can go miss, coronary artery dissection, but it's hard to link that to the facial edema. And we need to explain that. So I think for all those reasons, a primary histaminergic process that's leaving a imprint on the coronary vessel is most likely at play. Usually these patients who have vasospasm, they tend to be transient episodes. That SC segment goes down pretty quickly, and they're very responsive to nitrates or calcium channel blockers. So I think there was a good NEJM CPC on this, right, Robbie, on Kounis syndrome. It was in the past year. So I think that's a very good link for this case. But I'm curious to learn from Ashutosh what follows.
Yes, we were. I'm gonna reveal the final labs, and then maybe I'll talk more about that. So we ordered tryptase during the episode when patient was having chest pain, and as mentioned by Ravi, and I think I read Nova mentioning that in the chat that I need tryptase now. So we have tryptase for you all, and it was high. It was 20. The normal being less than 5 in most population. The normal is kind of different in depending upon the population as well. So tryptase was definitely high, and indeed it was diagnosed as a Kounis syndrome. And with immunologist involved, when she saw that tryptase is this high, so after the acute episode has resolved, the repeat tryptase was ordered, and the repeat tryptase was 11.6. So at this point, I came to know about a relatively newly described condition called hereditary alpha tryptosemia, which is like having a mutation of the gene that codes for the tryptase enzyme, and the patient is making a lot of tryptase, and which also predisposes the patient to multiple episodes of anaphylaxis episodes. And one thing is that this is like autosomal dominant in inheritance pattern. So probably the vague history from her mother was also indicative of similar kind of episodes, and probably she got that mutation from her mother. So the gene mutation called TPSAB1 was ordered, and it was found to be positive. And the patient was finally diagnosed with the final diagnosis was idiopathic anaphylaxis with Kuhn syndrome in context of hereditary alpha tryptosemia. I'm so amazed by you all in the chat, and Ravi and Reza. You got this one right. I mean, I think Seema mentioned about Kuhn syndrome very, very early on in the case discussion. I love presenting here. Thank you so much.
Ashutosh, that was absolutely incredible. Really, really. I want to reflect with you, but I feel like I've babbled a lot. I'm really curious to see what Prof. Rez is thinking.
I absolutely love this case, Ashutosh, and it's so incredible that like it was an actual patient that you cared for. And I think if I were to highlight the main takeaways for me is that we made pretty good diagnostic advancement on angioedema, because we said it was non-gravity, starts out unilateral, and is episodic. And then I think just being cautious before dismissing histamine because the lack of rash, knowing that you can't have a histaminergic process with no rash and angioedema. And then I think the chest pain and the ST elevation, that's what clinched it. There's no way you shouldn't be saying Kunis from the start just because someone has chest. They could be a million things. But I think once you get those ST elevations, and at that point, you might not know the link between angioedema and STL, but I bet if you Googled it or put it in GPT-4, it would come up, and just being able to identify and try to link the two problems. That's all I have. Would love to hear any final takes from you, Ashutosh, before giving the mic to.
Yeah, this case was very, it taught me a lot of things. The first thing that, that came to my mind is like, it reminded me is like to remember that anaphylaxis is a multi-system disorder. It's, and the thing that hit me when I was like learning through this case was like, there is this genetic condition and multiple episodes of anaphylaxis. When we see that in a patient, maybe we should think of that, because I was not taught about that condition in med school, and on digging deeper, I found that it was relatively newly described. So that was one thing. And the other thing, like Kuhn syndrome in itself was very interesting for me, because I have always been intrigued by the myocardial infarction, which shows like non-obstructive coronary artery in the cats. And but I had never thought like something related to allergies or hypersensitivity could be the pathophysiological base for something like myocardial infarction or ST elevation on ECG. That was one thing very new for me, and this case really taught me. Yeah, that's it. I think the other thing that I read about when I was studying like about Kuhn syndrome was like it has also been implicated in stent thrombosis, and so there are some paper where people say that maybe mast cell stabilizer can also be helpful for patients who are on like stent and those kind of stuff. Yeah, and that was very, very new for me. Like always, I've learned a lot when I present case here and otherwise as well. The chat was on fire. Lovely spending time with you all today. Thank you.
I'll just say one quick thing, Ashutosh, which is just to commend you on a fantastic case presentation. I think that you really set up the tension for us, and I think really, really enjoyed that that distinction. I'll get on my soapbox about one thing, which actually has been a theme of Friday VMRs. I remember having so much fun discussing a case of what turned out to be POTS syndrome with Prof. Rez a few months ago. You remember that, Prof. Rez? And that patient had a lot of mast cell type symptoms. And we were thinking about the overlap of mast cell activation syndrome and POTS. And I will tell you that I'm so grateful for RLR because Reza presented to me a very tricky case of angioedema that and that was the first time a week ago that I've ever read about hereditary alpha tryptacemia. 1 week ago, I created a new Evernote in my file that I just looked at again. And though I had completely forgotten this because it was only the first time I'd read about it, I just looked at that Evernote again and was like hitting myself for not thinking about it. Because don't hit yourself, by the way, it's a stupid piece of advice. I was disappointed in myself because I'm learning more and more that all these patients who have generalized anxiety, POTS, irritable bowel syndrome, many of them have underlying undiagnosed mast cell issues. And this is yet another example of a patient with GAD, IBS, actually having a mast cell issue as the underlying reason, likely, for all of those symptoms. So I think this disease, an expert, not me, even though I had read about it a week ago, I still forgot. But an expert would recognize this disease in aliquot number 2. Because if you have generalized anxiety and IBS and previous episodes of facial swelling, that should immediately make you think, is there an underlying mast cell issue here? And I am learning to form that connection. I read about it 1 week ago and forgot, but I would say that the signature of this hereditary condition also includes the GAD and the IBS. And very rarely in medicine do we have to make those things in red font on our VMR whiteboard. But they actually are today, yet again, another clue for mast cells. And so my soapbox is always think in your patients with IBS, autonomic dysfunction, POTS, GAD, do they have an underlying mast cell issue? I don't know how many of them will and how many won't. I don't know the relative ratio, but I can promise you this, that thought will help a small fraction of the patients that, at least a small fraction of the patients we care for. So I'm honored that that you brought this case to us, amazed that you were stumbled upon such a rare diagnosis in real life, and grateful that we get to learn from it. All right, Mario, good luck. I can't wait for your
Thanks, Brian.
Okay.
I'll need the luck. Well, there was a great, another great session of Friday VMR, which started with 2 chief complaints. One was acute chest pain and facial swelling in a young patient. So we learned that when we are facing acute chest pain, we have to rule out sinister causes like ACS, acute aortic syndrome, and PE, even though the prevalence in this age group can be lower, we have to still rule them out because of the high morbidity and mortality. And then we went through the differential diagnosis of ACS in young patients, which prioritizes non-plaque rupture causes of ACS, like coronary artery spasm, dissection, and embolism, among others. So after that, we tackled the second problem, which was facial swelling. And Reza gave us a great tip to use prior pictures of the patient to assess the basal status. So this would be the equivalent to look at a basal chest X-ray or a basal serum creatinine in different patients. And our differential for facial swelling included angioedema and superior vena cava syndrome and renal diseases like nephrotic syndrome. Reza also told us that if you're thinking about SVC, you have to look for the timing of the swelling in the sense that in the mornings, in cases of FDC, it should be worse and it should improve during the day. And in the physical exam, you should look for the Pemberton sign, which is increased swelling of the face and neck and plethora after 60 seconds of elevating both arms. And Rabih told us that if we add the semantic qualifier of episodic facial swelling, we should prioritize angioedema as a probable cause. Afterwards, when assessing a positive family history, we all tend to think about genetic causes that can explain both the disease in our patient and in a family member, but we also have to think about common infections and same exposures that the patients can be exposed to, like allergens. And after that, we talked about angioedema. So Reza told us that the first thing you have to do is rule out airway compromise and check the med list, because you can learn a lot about the disease just checking the med list. Afterwards, we learned that angioedema can be mediated by histamine, bradykinin, and leukotrienes. When it's histamine mediated, it usually has an abrupt onset and has usually urticaria associated with the angioedema, more commonly than not. And this can be caused by a prior sensitization, for example, a MET causing an acquired angioedema, or it can be also a pseudo-allergic reaction causing a direct mast cell degranulation, which, for example, is presented with opioids. We also learned that causes can be acquired or hereditary, either deficiencies or functional deficiencies in the bradykinin degradation in the case of bradykinin mediated. And afterwards, we also talked about that when you're thinking about hereditary causes of angioedema, the C1 is usually the culprit, and it can be either its dysfunction can either be a quantitative issue, if it's hereditary, or also a qualitative issue. The same as we know causes, for example, in platelet dysfunction, you can either have a platelet deficiency in thrombocytopenia, or you also can have a platelet dysfunction, or you can have a C1 inhibitor causing as a cause of an acquired deficiency. So afterwards, we also learned that the patient had an ST elevation, which we have to think about ACS, but it has a broad differential, including Takotsubo, pulmonary embolism, and myopericarditis. But we also found out that in the cath lab, the patient had a non-obstructed coronary arteries. So this prioritizes vasospasm, which can be caused by cocaine, other amphetamines, medications, but also histamine. And if we tie in ST elevations plus histamine, the syndrome that emerges is Cooney syndrome or allergic angina, which is a histamine-mediated coronary vasospasm, which can also present with Takotsubo. And there's a complex associated with this called the TAC complex, which is adrenaline, Takotsubo, anaphylaxis, and Cooney syndrome. So think about Cooney syndrome when you're thinking about histamine-mediated and coronary vasospasm. And last but not least, this patient didn't have only Cooney syndrome, but we also learned that he had a high tryptase, which led us to get a genetic test confirming the diagnosis of hereditary alpha-tryptasemia, which is an autosomal dominant hereditary disease, which is characterized by recurrent angioedema and anaphylaxis and a high tryptase in the laboratory examination. And finally, Rabih taught us that this disease, or the mast cell dysfunction syndromes, can also cause common diseases like generalized anxiety disorder, IBS, POTS, and autonomic dysfunction. So that's something to keep on our radar. So thank you very much, and hope to see you again soon.
Mario, I just wanted to give you a big hug. I don't know how you captured the teaching so eloquently. Like, just go back and listen to this. You literally summarized everything that was relevant in this case. And for those of you, just look at what one case taught us, from approach to chest pain in a young individual, approach to facial swelling, approach to angioedema, approach to histamine mediated. There's so much learning to do, but maybe you just focus on one component of this so you don't overwhelm yourself. And then this will repeat itself in the future. Like if you're creating an illness script for Cooney syndrome, that's probably master level. If that's like Rabih level should do that. The majority of us should be focused on the various arms of this presentation. And then little by little, like interest that compounds, your knowledge will compound. And then you'll be making these links very quickly. But Rabih, isn't this incredible?
Yeah, I'm so Professor, so well said. So well said. And yeah, I mean, I think it's just such a privilege to be able to share these cases and discuss them with you. And a big thank you to everyone who makes the time to join us live. And a smaller thank you to those of you listening on YouTube. I'm kidding. We're still grateful to all of you, but you should come and join us live. It's way more fun. All right, y'all. See you next time. Oh, I think Elena, if you're still there, you're the host of the meeting, so I think you have to end the meeting.
Okay, this is gonna be another challenge. Let me see.
You got it?
Okay, I think I can handle it. Yes. Bye, everyone.